So all of us who are urologists have this gray zone between 4 to 10. It varies because right now the recent guidelines are with age appropriate PSA levels, but in general 4 to 10 PSA, total PSA between 4 to 10 is still considered as a gray zone. Why is it a gray zone? Because PSA is organ specific but not disease specific. What I mean is that PSA could be raised in cancer of the prostate, PSA could be raised in infections like prostatitis, or if there has been any recent instrumentation which can elevate the PSA levels. Now, in this diagnostic gray zone, do we have anything which can help us differentiate between a cancerous lesion and a benign one? So 25% of So nearly 25% of men in this gray zone are ultimately diagnosed with cancer of the prostate. And if you take between 4 to 10 alone, almost 75% undergo an unnecessary biopsy, which is only determined only by the PSA. Now, how sensitive is digital rectal examination? Well, honestly speaking, how many of us do a digital rectal examination on every patient who comes? It has to be done, I know, but honestly speaking, one-to-one, how many of us really do it? Even if we do it a diligent digital rectal examination, we are very likely to miss any lesions in the anterior zone, or in the apical zone we can. Transitional zones lesions are again not very well palpable. So what was previously, even when we started probably, we used to do something called as finger guided biopsies. Now there's more risk to the surgeon's finger rather than taking the right core. So it went on, we transferred to a transrectal ultrasound guided biopsy. Now even the transrectal ultrasound guided biopsy is only guided by an anatomic template. We don't have any functional things because generally books tell 60% lesions are hypoechoic, 30% are hyperechoic, and 10% can be isoechoic. So if you see, even just a transrectal ultrasound is likely to miss at least 30 to 40% of lesions in the prostate. And when this happened, when we did a systematic 12-core biopsy, what happened? There was over-detection of indolent disease, but under-detection of clinically significant cancer together. So as I said, it samples the geography, not the pathology. Up to 1 in 3 clinically significant prostate cancers can be missed. Indolent diseases, a low-risk disease, is overdiagnosed, adding to the apprehension and anxiety for the patient. And if there is a negative biopsy, then what? We have patient scenarios who come back to us with persistently elevated levels, say between 9, 10, and whatever course of antibiotics you have given, whatever alpha blockers we have chosen, the PSA refuses to come down. So then what? We have this, a multi-parametric MRI and a pyrite scoring. So basically, a multi-parametric MRI has 3 components. One is to know the tissue architecture by T2 weighted images. Second is the cellular function by the diffusion weighted images with ADC. And last is to know the vascularity of the lesion by a dynamic contrast examination or enhancement. So these 3 are an anatomical as well as functional tool to say whether a lesion is taking up more contrast, is having a significant DWI with a low ADC coefficient, which will help us to target these lesions better. So it is like to see the target before even we prick the person. And I think all of us would agree, if you have a clinical suspicion of carcinoma prostate with elevated PSA, right now the diagnosis or the investigation modality of imaging investigation modality of choice is the multiparametric MRI. So regarding the pyrite scoring, I leave the job to our esteemed Dr. Santosh, who will be giving us a detailed overview of what is the MPMRI as well as the pyrite scoring system. But broadly, 1 and 2 are benign, 3 is equivocal, and 4 or 5 has a high likelihood of carcinoma prostate. So what techniques are there where we can fuse the MRI image to the transrectal or the transperineal prostate biopsy? So basically we have a cognitive fusion. That means I, as a urologist, have seen the lesion on the MRI. I have an image in my brain. Suppose it is a right peripheral lesion, whether it is anteriorly placed or posteriorly placed. And then I do a transrectal or transperineal ultrasound and imagine that lesion to be there, and I biopsy it. So that is cognitive. Second is software fusion, which we have here what is called as the MRI fusion biopsy, where the target can be seen live on the live image because we have fused the MRI images onto our live ultrasound images. So that is a software fusion technology. And the last is in-bore biopsy. I don't think many of us have even had experience of an in-bore biopsy where it is performed directly inside the MRI scanner. But it has got the highest target precision. So there are 3 trials. One is a PROMIS trial, precision trial, and the MRI first. Why am I telling about these 3 trials? Well, all of us till now, based on the talk which I have been giving, I think we have been saying that MRI targeted biopsy is the way to go. But does it answer the question that if you do a multiparametric MRI and if it is negative, are we confident just to avoid doing biopsy altogether? Now, if you see the PROMIS trial, there was 576 who have never undergone biopsies but a clinical suspicion of prostate cancer. Every man underwent a multiparametric MRI and then a standard 10 to 12 core biopsy and a template prostate mapping biopsy as a reference standard was done. And the question being asked was, can a multiparametric MRI used as a triage before biopsy, like I said, whether they can identify men who can completely avoid doing a biopsy? So if you see, the sensitivity of the multiparametric was significantly higher than the standard 12 core, and the specificity was very good because the true negatives will be excluded, and the negative predictive value is also quite high. So the strength of the multiparametric MRI is ruling disease out. So a negative scan should be reassuring. Then came the precision trial, but most of these are done in the UK, where arm A had an MRI targeted pathway, arm B had a standard pathway of a systemic 10 to 12 core biopsy. And what was the primary endpoint? It was to detect clinically significant prostate cancer. Various definitions of clinically significant prostate cancer have been there, but all of us would agree right now that any grade group 2 and above will qualify as a significant, clinically significant cancer, because grade group 1 and 2 can still undergo something called as an active surveillance, which are already come into the guidelines. But in this, you can see that MRI with a negative MRI patients completely avoided biopsies. So again, clinically significant cancers were detected 38% in the targeted pathways, and clinically insignificant cancer was detected only 9% of the MRI targeted pathways. So this slide gives a broad view as to say that clinically significant cancers can be detected better if you do a multiparametric MRI targeted biopsy, and indolent or low risk cancers can be avoided by doing a multiparametric MRI. Only drawback of this study was patients with a negative MRI never underwent any sort of biopsy, so we don't know what happened to them. Now, to counterpoint to all this, both the studies said that MRI targeted pathway is better. Now, the MRI first is a counterpoint, which is it was published in 2019. In this, the patients underwent both a targeted biopsy as well as a systemic 12-core truss biopsy. Now, the finding was that detection rates of clinically significant cancer were statistically similar between targeted only and systematic only biopsies. But if you combine both, they detected more cancers than either approach alone. Now, what should be the standard? Whether you do only a targeted biopsy or a combined TRUST and a targeted biopsy is again one of the discussions for the panel. If you do this, if you go by this study, then the whole point of doing a multiparametric MRI to avoid biopsies is a big question mark. So I've put both the three studies to just have a broad introduction into what we are going to discuss today. So this is just the summary of the findings of each study. But if you see, the European guidelines are more oriented to doing multiparametric MRI in biopsy naive men. But if you see AUA guidelines, they only support its. In EAU, it's a strong recommendation. In AUA, it supports a multiparametric MRI before biopsy in appropriate candidates. So the AUA guidelines says that it should be endorsed alongside, but not strictly replacing a systematic sampling. So if you take all the guidelines together, if you put a common thread, then it is the MRI targeted biopsy is now embedded as the standard diagnostic pathway, and the debate has shifted from should we use MRI to how should we target and systematic course be combined or not. So what is settled? Pre-biopsy MRI obviously improves detection of clinically significant cancer, but does a negative MRI support safely deferring biopsy in few patients? That's a question still needs to be answered further. And targeted biopsy reduces overdiagnosis of indolent disease. These are all shown by both the PROMISE and the precision trials. Now, what is still contested is, like I said, whether targeted biopsy alone should be done, and MRI interpretation is again variable. Like in centers where we do multiparametric MRI in our hospital, I think Dr. Santosh would be reading a few hundreds of them, whereas in a peripheral center, if you get a multiparametric MRI, the radiologist who doesn't have significant experience in locating these lesions may miss it. Obviously, the cost adds because a multiparametric MRI itself is not cheap, and you add that to a fusion biopsy, which is going to add to the cost. And then equivocal. So what is equivocal? Even in our experience, a Pyrites 3 lesion, we don't suggest not to biopsy. We biopsy all Pyrite 3 lesions as well. So what is the optimal management is still a big question. So key takeaways: it has multiparametric MRI has made a blind procedure into a targeted one. I have talked about the 3 trials, but what should be the standard is still in the guidelines are yet to say what is definitely going to be the standard. So I'm I'm opening up this session with, I'm inviting Dr. Santosh, who's going to speak on multiparametric MRI and the pyrite scoring. Please come, sir. Dr. Santosh is our head of department of radiology at Fortis Hospital's Banarghetta Road. He heads a big team, and he's always been there for us any time of the day or night, giving a call. And even in his absence, he sits at home and reports these multiparametric MRIs for us. Thank you for coming, sir.
Thank you, Dr. Karthik. I think like what Dr. Karthik said, I think thanks to the urology department, Dr. Mohan Keshamurthy, Dr. Karthik, and all leading the team, I think we've, as a radiology team, has evolved in the interpretation of MRs. With a growing number of MR prostates, I mean, he has really created an environment where everyone is kind of benefited. So we as radiologists, the technicians, everyone is now quite experienced in the interpretation of MRs and all that. And probably I think we are one of the, I won't say the biggest, but I think I can safely say that we are one of the biggest centers to have the number of MRs which we are doing for CA prostate. So today we'll look at the pyrides, which is the imaging and data reporting system. Just like the pyrides, the radiology has evolved with 1, 2, 3, 4, 5, where mostly the 3 is equivocal, 1 and 2 are benign, and 3 and 4 and 5 are generally considered more towards the malignant aspects. So why MRI? I mean, he's already told all this. I think he has covered a lot of it. MRI has the best soft tissue contrast amongst all the modalities. MR has the best soft tissue contrast. Like it also identifies suspicious lesions and gives a pyrite score. And then a high-risk lesion can be biopsied and also allows targeting of the lesions that were identified on the MR. Now we've already seen that PSA testing is insufficient. Most trust biopsy techniques will miss about 30 to 40% of the gland. So it is now the accepted first path of entry for most patients that are ultimately diagnosed with CA prostate. So when we do MR, we are looking at 3 parameters, that is the conventional T1 and T2 sequences, the diffusion weighted imaging, and the ADC maps. So the conventional T1 and T2 defines, the T1 defines the anatomy, the T2 defines the pathology. So most anatomy is based on the T1 scans. The T2 scans will shows the pathology. The diffusion weighted shows the stromal density of the lesion. So basically higher stroma will look darker, and more fluid or benign lesions will look brighter. And the ADC, which again defines the stroma, which indicates the density of the lesion. I won't go to the precision and the PROMISE trials. So in the past, the prostate was, with the, like he said, with the digital guidance. With the introduction of transrectal ultrasound, it was, guiding the urologist's finger, and all of them may not be seen on conventional ultrasound when ultrasound took over the DRE. Now, the earlier it used to be something called as a systematic biopsy, which most of us agree now that it is something similar to a blind biopsy in the after doing the DRE. So how the pyrides evolved was, we had a version 1 and a version 2. We now have the version 2.1. So what actually the version 1, one of the main indicators, one of the main parameters in version 1 was the MR spectroscopy, which is now taken out. No sequence was really dominant. So the T1, T2 or the diffusion or anything. So no sequence was really dominant. Version 2, started having the MR spectroscopy was no longer done, and there was only a minor role for contrast. The overall assessment remained as 1 to 5. Now we have the version 2.5. So another thing is we use the 39 sector map. I'll come to that when we are interpreting the version 2.1. and we also give contrast. The version 2.1 basically defined dominant sequences. For example, the dominant sequence for peripheral zone lesions is the T2 and the diffusion weighted sequences, and the tiebreaker is the contrast. For the transition low zone lesions, the dominant sequence is the T2 and the tiebreaker is the diffusion weighted sequences. Contrast may not be necessary for transition zone lesions. So this is what the 2.1 defined, and so we had a refined transitional zone criteria with a refined diffusion and ADC assessment. So how we do is the 3T imaging. We have a 3T state of the art. We have a 3T with an AI. So what does the AI do? So when we take up the prostate and all that, automatically the sections align with the around the prostate. So we really don't have to do anything. The more number of we do, the more number the machine keeps learning, so that the sections stand around the prostate. And of course we have to a little manipulator here and there. So we now use a 3T MR. So earlier when MR started, actually there used to be a lot of endorectal coils. So we no longer use the endorectal coil. We, the signal intensities and the contrast is extraordinary with the 3T imaging. So we no longer use that. The conspicuity is very best seen on 3T MR. So now we know that the 4 and 5 lesions have significant carcinoma, and so such lesions are seen in the anterior gland, posterior, apex, low, mid prostate, so which are generally difficult to see on ultrasound. The other thing about 3T is that we may be using contrast to define the conspicuity of the lesions better, and also gives a the information about the local spread, adjacent structures, seminal vesicular involvement, lymph nodes, bones, all of these are all also assessed when we do the MR. So this is what it was. Earlier it was used mostly the sector-wise involvement here. Now we use a MR for assessment. So how does the MR help? Accurate biopsy, we stratify the risk into low risk, intermediate risk, and high risk. We all know that where PSA less than 10, 6, 7, and 8, appropriate treatment. So accurate biopsy will further lead to further best treatment for patients. So this is how it is done. The MR prostate takes about 28 to 30 minutes, and then the diagnostic interpretation with the radiologist, and then it is sent to the fusion console, which takes about another 30 minutes. So the entire thing, if actually planned and all that, will seamlessly integrate into the MR fusion biopsy console. So this is the 39 sector map. So basically we include the membranous urethra, the 2 seminal vesicles also are included, and the 36 gland. So from the base, the mid, and the apex prostate. So each one is divided into the anterior and the posterior zones, or the sectors, and the lateral sectors here in the mid apical prostate, and the anterior fibromuscular stroma is one more on either side. So basically it includes the base, mid, and prostate levels here, which will make it into 36 plus 2 plus 1, so which is a 39 sector map. So when we give a report also, we are expected to give where is the lesion. For example, if the lesion is in the right posterior sector, we give it as a right PZP, which essentially means it's in the posterior sector map of the right peripheral zone in the mid prostate, low prostate, apex prostate. So we define that. So they will also be able to fuse the posterior, like the PZP on the ultrasound, for a targeted biopsy. It's the same thing, which is again, so this is again showing a lesion in the mid prostate posterior sector here in the PZP. So this is what is seen on the ultrasound, and so will make the targeted biopsy more efficient. So what else is also done? We also measure the prostate. Here we also measure the prostate. We also do a PSA density. So anything a PSA density of more than 0.2, this is a rule of thumb rule kind of thing, contributes to more clinically significant prostate density. For example, here on the measurement, the PSA was 5 and the PSA density is 5, so 0.09. So low PSA density, so less chance of a clinically significant cancer. So coming to the anatomy of the prostate, this is in the mid prostate. So like I said, these are the three basic sequences which we do. So this is the T2 weighted sequence. So this is the transitional zone here, and this is the peripheral zone, which is homogeneously bright. And this is the transition zone. You can see these are the nodules, the benign prostate nodules, which normally should have a very well-defined hypointense margin. So well-defined hypointense margins essentially means they are benign. So more malignant nodules will lose this margin of hypointensity around the margins here. So a malignant lesion in that sense will look homogeneously dark, which what we call as an erased charcoal appearance. So as if you have brushed a charcoal, so it look dark with poorly defined margins. So the peripheral zone is generally bright here like this. So any lesion will be dark. So this is exactly the reverse of MRI and anywhere else, where on T2 most of the lesions will look bright. For example, in a brain, if you look at a positive lesion, whether it's a granuloma or a tumor, it would look bright. So in a prostate, it's exactly the reverse. In a peripheral zone lesion, it would look dark instead of a bright lesion. So this is an abnormal. So where the lesion would look dark here, the diffusion weighted where it looks bright, and this is the T2 which looks dark. So this is the lesion on the DWI on a normal here. So this is a lesion on a bright where it looks dark, and on the ADC it looks very dark because it has got lot of stroma. So it looks very dark here. On the transition zone, like I said, again most will have dark benign nodules. This is what it is. So this is a benign nodule. If you look, a very well defined hypointense margin. But here if you look, actually there is hardly any margin. What I said is a erased charcoal appearance. So again, like I said, the diffusion is the is the T2, and the diffusion is what determines lesions in the transition zone, not the contrast. So coming to the peripheral zone like lesions, I won't go into the 1 and 2, where it is 1 is mostly normal and 2 also is mostly like prostatitis and mostly normal. How we do the 3 is that it looks dark here on the T2 peripheral zone lesion. ADC is not so dark here, so this would fit into a Pyrides 3. But if you give contrast, like I said, is a tiebreaker. If it enhances, then it becomes a positive. We can upgrade it to 4. If it doesn't, then it remains as 3. So you should remember that T2 dark hypointense lesion, but with no significant restriction. Restriction means becoming dark on ADC is called restriction. So it's not really dark on ADC. If it's moderately dark on ADC and then it becomes a Pyrides 4, and it will enhance on the contrast, but the lesion is about less than 1.5 centimeters, so it becomes a 4. If the lesion is more than 1.5, it becomes 5. So that's the main difference between 4 and 5 is the size of the lesion, where it becomes 3 and 4. Of course, you also see if it's an extra prostatic extension, directly goes to 5. The transition zone lesions similarly will look dark on T2 and without any diffusion restriction. So Pyrides also not only has defined the how to interpret the T1, T2 and the diffusion weighted images, it has also given us how we should do the MRI. So we in Fortis actually have followed the pyrites protocol as per like what they have given. So we use, like for example, 3 millimeter sections with no interval, what we call overlapping or the contiguous sections. Also we conform to the the field of view how much it should be, and even the diffusion weighted sequences we follow what is called as the 1400 B0 value. So these are all values when we do MR. So these are all very important when a particular MR is done. So like what Dr. Karthik was telling, all these are also important when an MRI is done. So this all aids. I mean, this is the typical MR where a radiologist should be interpreting, not just like a routine MR of the pelvis or the prostate with different parameters. If all these parameters are followed, then it becomes a typical pyrites MRI. So again, this is the same thing. So like I said, the summary of 2 is 2, 3 is negative if there is no contrast, no enhancement. If it becomes enhancing on contrast, it upgrades to 4. Similarly in transition zone also it's the same. If it's 2 and if there is a positive on diffusion, it directly upgrades to 4. And the 3 also upgrades to 4 and 5 if there is a positive on diffusion. So how the other mimics are prostatitis, which generally looks like a wedge-shaped lesion in the peripheral zones here, and these are all hypointense, but this is like another T2 hypointense lesion like in CA prostate, but which has no diffusion restriction here. But as you see, there is a lesion here which shows diffusion restriction becoming dark on ADC and bright on diffusion. So this is a CA prostate and this is a prostatitis where there is hardly any restriction, but both of them will look similar in the sense they are slightly intermediately dark here and hypointense intermediate to more dark on T2 weighted images. So what all we do, so there is an indication, PSA, the biopsies, the prostate volume we mention. We also mention the density. We also mention if there is post-biopsy hemorrhage. We need to the lesion characteristics on a 39 sector model like I said. We mention the T2, the DWI, and if there is any extra prostatic extension. Finally, a pyrites classification. So what all are the mimics? Like I said, is a benign prostate where you have a hypointense nodule which has to be completely encapsulated, means a fully hypointense margins around the lesion. Any any loss of margin is suspicious for a malignancy in a transition zone. Prostatitis I showed, that is dark on T2 or intermediate to dark on T2, but does not show diffusion restriction, means it is not becoming so much hypointense on diffusion. Then a post biopsy hemorrhage will look, like I said, we do T1 for anatomy. Anything which is bright on T1 is already hemorrhage, so we can be sure that there is already hemorrhage. Generally we avoid doing T1 hyperintense. We have to generally after a biopsy, if a biopsy has been done earlier which is negative, generally it is better to wait for 6 weeks before we do another MR, because this T1 hyperintensity will interfere with the contrast when we give contrast zones. Central zone lesions are symmetrical, low signal. The anterior fibromuscular stroma is low T2 but no diffusion restriction. The stromal hyperplasia, the hypertrophic surgical capsule, calcification fibrosis, these are all which are normally seen sometimes and we need to be careful about it. This is what is pyrites. This is the standard reporting format. So where we have that, like I said, everything is the name, all the biopsies, MRI scans. We give a 39 sector model like this and then we report the. So coming to cases, I'll show some 3-4 cases. This is a typical, this is a small transition zone here. This is a large peripheral zone, fairly homogeneously hyperintense. You can see a T2 and hypointense lesion on this, on the transverse section. You can see clearly it is in the lower prostate, posterior segments here. This is very bright on the diffusion weighted images, and this is very dark on the ADC. So we mentioned we measure the ADC. This normally should be less than anything less than 0.8. We measure in 10 to the power of minus 3. Anything less than 0.8 is generally suspicious for a dense stromal lesion, which is indicative of a mass lesion or the neoplasm. So it should be bright on T2, and it should be on diffusion, and should be very dark on ADC. That means it's a dense stromal lesion suspicious for malignancy. This was a Pyrides 5 lesion. I'll show you why it is Pyrides 5. So this also has an extra prostatic extension here. When you see it, it has bulged out of the capsule here. You can see normally the T2 hypointense capsule here. So any break or the disruption of the capsule here will indicate extra prostatic extension. In addition, we also do, when we give contrast, we do what is called as MR perfusion studies. So we assess the functionality of the tumor when we do this. So you get a color map like this. We assess the perfusion. So you can see a intense uptake of contrast here, and then a washout of contrast. So this indicates the immediate uptake and washout of contrast. So these are called MR perfusion studies, which essentially means that the tumor is vascular, takes up contrast, and washes out. We also do what is called as a permeability studies on that. We measure the K-trans and the KEP and all that. These are all MR parameters. Basically indicates the concept is that most malignant lesions will have neovascularization. So these are basically having some friable vessels with very porous vessels. So this is the reason for an immediate uptake and excretion of the contrast. This is another lesion in the clear lesion, very T2 hypointense, dark, situated in the AFS, very dark on AFS here on the sagittal images. You can see it's bright on the diffusion weighted images, and very dark on the ADC. Again, if you see the ADC measures about 0.6, again suspicious for a malignancy. Would not be very well seen on a ultrasound or a DRE. This is another transition zone. This is a recent one where you can see a hugely enlarged prostate. There's absolute loss of the margins between the transition and the peripheral zone. The whole prostate looks fairly homogeneous here. This was a known case of CA bladder, so the PSA was about 33. You can see the dilated ureter here. The left ureter is dilated. So this was done whether to see it was a CA prostate. This looks very homogeneously dark on T2. There was not so much diffusion restriction. Fitted to a the creatinine was 2.4. However, we could give a contrast, but the patient refused, so we didn't give contrast. We gave it as prostatitis. I don't have a follow-up on this, but the clinically also a suspicion was prostatitis here. This is another lesion in the transition zone. Like I said, most nodules will have this T2 hypointense lesions, very typical for a benign nodule. If you see this nodule, there's hardly any margin here. Like what I said is typically classically described as a erased charcoal. This was hyper intense on the diffusion and very dark on ADC, which showed about 0.8, indicative of a malignancy. There's another one which showed a very small lesion. The size of the lesion was about 6 or 8 millimeters. These are the types of sub-centimeter size lesions. Also, we can pick up on MR because of its good soft tissue resolution. This was a post-TU RP with a well-defined collection here. You can see a hypointense lesion with inner, inside there is a lot of debris inside here. This was a prostatic abscess. again showed dense, the fluid intensity or diffusion. So the important thing to remember is prostate abscesses also show dense diffusion restriction. But the thing is, they all show variability in the margin. They also show irregularities. They also show wall enhancement when we give contrast. This is one of the indication for a contrast when we do the study. This is one of the recent one. I think this is an ongoing study here in our hospital, where we have had about 112 patients, and the MR fusion biopsy showed about 91% sensitivity and specificity about 91%. This is preliminary data on one of the studies which in our hospital we are doing now. So one of the common questions which all of us ask is whether contrast is really necessary or not necessary. Now, if I see a pyrites 4 or a 5 lesion, a lot of times we may not need to give contrast also. We don't even need contrast except to define the lesion better, maybe to assess the surrounding extra prostatic spread. So what contrast enhancement is demonstrates is early enhancement due to new angiogenesis, which is an indicative of a prostate cancer. Where it matters really is in pyrites 3 lesions. It's a tiebreaker. Any contrast enhancement will elevate it to upgrade it to a pyrites 4 lesions, or it can remain as pyrites 3 if there is no enhancement. Another thing we are commonly asked is, can we give contrast in a patient with a high creatinine? Now the recent, so in our hospital, we have almost stopped doing creatinine for when we do MR patients. So the latest ACR criteria, that is the American College of Radiology criteria, is now telling that there is no need to, you can absolutely safe to give contrast even in a elevated creatinine situation where the GFR is even less than 30. So the current guidelines, they are extremely safe, even patients with eGFR less than 30 when contrast is clinically indicated. So contrast, we have to take a call that it is better to give contrast and not avoid contrast. There is absolutely no contraindication now to give contrast when we do these examinations. In fact, we have almost stopped doing creatinine for all patients. We've been using, so in contrast again, there are group 1, group 2, group 3, this one. We've been using the group 2 contrast for about, close to more than 10 years now. So absolutely no risk of NSF or anything in patients. So this is what is another one. BP MRI is the contrast is a MR without contrast. When we use contrast, it's called as an MP MRI. So like I said, the contrast is the tiebreaker in peripheral zone lesions, and the diffusion weighted images is the tiebreaker in transition zone lesions. So what is the index lesion? So when we see multifocal, the concept of index lesion comes when we see multiple focal lesions with similar morphology and pyrites scores. So when we see lesions, the lesion with the highest pyrite score is called as the index lesion. Now if there is a tie with the similar pyrite score of both lesions, then the lesion with the extraprostatic extension is considered as the index lesion. Even after that, if there is a tie with all of them being similar, then the largest lesion is considered as the index lesion. So these are the basic concepts of pyrites interpretation. Thank you.
Thank you very much, sir, for enlightening us on the pyrite scoring and the multiparametric MRI. Any questions? Anybody in the audience can have? We can answer for a 5 minutes or so.
So we use, now like I said, we are using the group 2 contrast. So we are using, there are 2 group 2 agents in India. One is called as a Dotaram. from Braco, and one is called as the Gadovist from Bayer. So we've been using them for a lot of time. They are what is called as multicyclic agents, absolutely safe for all contrast MR studies. Yes, sir. No, CT. So we are looking at two things. So you are looking at on the MR, the concept of contrast being used or not being used is the issue of NSF. Whereas a CT contrast, you are talking about nephrotoxicity. We are not talking about that. No, CT contrast is not there. We are talking about MR contrast and the issue of NSF. There, the renal toxicity of the in CT contrast still remains. So that is still a guarded issue. Yes, sir, please. Sorry, I didn't get your.
What is the variability among radiologists in assigning pyrite score? Among radiologists.
So, like I said, no, we have to be very clear in forming a pyrides protocol. So we, as this one, we have stuck. So, like I said, not only they have given the pyrite score, how to interpret, they've also given how the MR should be performed according to the pyrites protocol. So, for example, the 3 millimeter sections, overlapping sections or contiguous sections, how much should be the field of view, how much should be the B value. B value is the diffusion weighted imaging. What is the kind of B value we are giving? So if all parameters are fixed, then it actually fits into what a typical pyrites protocol should be. So if you follow a strictly pyrites protocol, most of us radiologists will be able to interpret this. But the problem in radiology is, as you know, is very subjective. Most of the time it is done because the protocols are not followed. That's the reason. If you follow all protocols, then I think you would be able to pick up a lot more lesions. Like I said, we will be able to pick up even small sub-centimeter size lesions in the various zones. Yes, sir. The T2, sir. T2, yeah, T2. Yeah, because like I said, the contrast or the diffusion are mostly tiebreakers. But the T2 will have the highest resolution and will be very well seen, including the extraprostatic extension which I showed. So if you are very clear about the T2 lesion, we can use this. We in our hospital also use the T2 lesions. Yeah.
Common question amongst all of us is when we send a patient for a multiparametric MRI, is there any specific preparation which needs to be done for the patient? For example, whether he should be fasting, whether he should pass his stools and come, whether he should empty his bladder, whether these questions are very commonly asked by the patients to us. So can you enlighten us on that?
Yes. Thank you for that. This one, I think we keep telling that. Absolutely no fasting required. MR contrast is not at all allergic. We've done so many this one in the last maybe 20 years of my this one. Maybe we have seen some 4 or 5 minor reactions with MR contrast. So hardly you can absolutely consider that it is a safe drug. So there is no need for vomiting. There is no need for fasting. So we can give it any time. One thing we need is, which is kind of difficult, I would say, in a clinical practice, is adequate preparation. We need the patient to pass motions because the fecal matter in the rectum is going to interfere with air artifacts on the MRI. So we would ideally have, fully prepared rectum. But like I said, it may be difficult when, we are short of time, patients have come from elsewhere. Patients don't have time enough to spend like that. So we are clinical logistic issues. So we are, but ideally, we will need adequate preparation for the, before the MRI is done actually.
I think the 3 Tesla with reduced signal to noise density, I think makes our lives easier than the 1.5.
No, absolutely. I mean, so way to go is to 3T. It has the best soft tissue resolution. It almost has now replaced the endorectal coil, which actually was used because it is closer to the prostate and which gives excellent imaging for the prostate. So now 3T has replaced the endorectal coil. So if you have a choice in a hospital with a 1.5 and a 3T, you should go with a 3T. Of course, if we don't have, we can still do the 1.5. It's also good enough, but maybe not as good as 3T, of course.
Thank you, sir, and thank you all for a very vibrant discussion on the multiparametric MRI. Now that we have targeted...
Thank you,
yeah,
Dr.
Thank you, sir. So now that we have seen where the lesion is, we have targeted the lesion on the prostate. We'll go through a few steps or technique of procedure, how we contour the prostate and mark the lesion before we go ahead and do the biopsy. So I have with me Dr. Suraj, who's a consultant urology at Fortis Hospitals, Banargata Road.
Hello, good morning everyone. Now that we have, as Dr. Karthik rightly said, we have finished learning about the MP-MRI, the role of it in diagnosing prostate cancer and also how to read an MP-MRI. Now let's put it into action by using it to mark the lesion on the prostate and also take targeted biopsies from it. So what we use at Fortis Banargata Road is the BK5000 system, and it is associated with a software which is used for contouring of the prostate and also marking the lesion. The software is called as MIM. So now I'll just cover a few things around before we go into a practical demonstration of how we contour on the MIM software. So why we need to fuse the images for the MRI fusion guided biopsy is that, so now we have an MRI which shows a particular lesion in a particular spot, but when we just read the image and do a ultrasound guided or a transrectal biopsy, so it is just a cognitive biopsy. You might not hit the exact area, but if you do a fusion biopsy, it would be exactly from the space or the place from where you have actually marked the lesion. So that would be a better way of doing it. And here in the BK fusion system, so this would be the workflow. The first thing is to acquire an MP-MRI. The second thing is to contour the gland and then mark the lesion. Then the entire software is uploaded onto the BK fusion system. Then we do the predictive fusion, that is we mark the contour of the prostate which is there onto the ultrasound image, and then take the targeted biopsies. So what are the prerequisites for having this before we start the contouring of the image is we have to have a T2 weighted image, we have to have a diffusion weighted image or a ADC, dynamic contrast image, enhancement image, and the slices, as Dr. Santosh was previously telling, it is always better to have the slices of MRI to have less than 3 mm slices. So the first step is to import the images onto the MIM software. So once you have imported, then you have to select these 3 sets of images, that is T2 weighted images and also the ADC and the DC images. So once that is done, then we start marking the prostate on the on the T2 weighted images and make the marking of the contour of the prostate right from the base of the bladder until the apex of the prostate. So once that is done, then the images are interpolated and then we go ahead with marking of the lesion. So we observe the lesion on the T2 weighted image and suspect this area to be suspicious, and also take the help of the reporting given by the radiologist, and we go back and cross check the images on the ADC as well as DCE to see how the suspicious area is becoming dark on ADC and also becoming bright on DC or what. So once the suspicious area is seen, and that would be marked along, and then the entire thing would be exported out. So what is this predictive fusion and why is this important? So the MRI images are in a different angle, or the images are in a cross-sectional imaging. But when you are doing a truss biopsy, it is in a different, the prostate lie is on a different angle. So when you fuse these images, we'll have to align the contour of the prostate to the angle at which the patient is lying, either in the Sims position or the lithotomy position when we are doing the biopsy, so that the prostate aligns with it. So this is called as predictive fusion. So this is important over here. So best practices for accurate contouring, again, use of the highest quality of the series, keep slices thickness consistent to less than 3 mm, double check on patients matching, that is the same patient MRI which has been transferred, and re-verify after repositioning. So the pitfalls could be, if you don't mark the gland completely from the base of the bladder until the apex, sometimes people do just mark the lesion and try to take a biopsy out of it. That time, with every small movement of the patient, the contour or the lesional area might keep on moving, which could be mistaken. And skip patient mismatch again, and no mid-procedure re-verification. So during the procedure, we should always keep verifying whether the marked area is in coordination with the prostate on the ultrasound as well. So I'll tell you when I'm showing the video what happens, because if the patient moves a little, or he moves his limbs, so that is when the markings moves away. So you have to always keep verifying it in between. So this is a video showing how do we contour the images on the MIM software. So once you open up the MRI software and you upload the patient images which are taken from the RESPACs or the images from the MRI from a CD. So you can see I have marked these images, which includes T2 weighted images which are in coronal and sagittal form, and also dynamic contrast imaging and also ADCs. So these would be imported into the software and confirm the patient's name, that is Mr. Suresh Pai, and along with the report and also the patient himself. So once these images are imported, then the software itself realigns all of those images which have been, the group of images which have been there, just reconfirm that they are in the same place. Like T2 is matching T2 and ADC is matching with ADC and DWI is matching with DWI. And then once that is done, confirm it. And now the software is ready to go ahead with the contouring process. So you get the T2 images over on the right up corner and the other images next to it. So first, marking of the contour of the prostate, just observe throughout the gland from the base of the bladder to the prostatic apex. So you mark the 2D brush over, there is a mark called 2D brush over here, and also the prostate. So first click on the prostate and then the 2D brush mark and start marking the prostate in this way. Peripheral zone. reshaped it. Yeah. Yeah. Ayyo. So if you can observe here, once we have marked the contour of the prostate, so coming onto the peripheral zone, on the right side, it appears to be darker, and on the left side, it is more hyper intense. So the left side of the peripheral zone is actually the normal peripheral zone. This is the normal peripheral zone, but here is something which appears darker. So this is the suspicious area of the tumor. So once the prostate is contoured, so then we go ahead with the lesion marking. So before we mark the lesion, we interpolate the contour. So keep the lesion marking ready, and so we go back and check on those images and the ADC and dynamic contrast imaging as well. So the same lesion appears brighter here and darker over there. So now we have the suspicious area, so that we go back and mark on the so once the lesion is marked, then we need to adjust the contour of the image along with the prostate, so that, see, this will be showing the probe, and this is the prostatic contour. So basically this will give us a picture what we are going to see on an truss image, basically, because the patient would be in the sagittal plane. And once the grid alignment is fixed and you save it, so once that is saved, you close all the sessions, and then you get the software ready to be transmitted. So key takeaways, accurate fusion biopsy begins on MRI, a complete whole gland contour base to apex plus a which is fully outlined, not just pointed at the lesion. BK fusion's predictive fusion uses those MRI contours and rigid registration to fuse onto live truss without redrawing the prostate on the ultrasound. Verification doesn't end at the registration, confirm with the patient and the reports during the biopsy as well. Structured lesional documentation and biopsy target is agreement. Thank you.
Thank you, Suraj. So, at our institution, the contouring is done by a urologist ourselves. But in many institutions, I think the radiologists contour and keep the target and then give it to us. Because the software is very costly, I think that's why we have restricted it to our department only. And once we have targeted we have drawn the contour, we have targeted the lesion. So, I'll go through the technique of how we do the biopsy. Before we do the biopsy, is anesthesia really necessary? So why should we anesthetize the patient, whether it's local or periprostatic block? And to know that, we should know the target anatomy to say where actually the nerves run around the prostate. It could be a transrectal or a transperineal block, because we should optimize the patient's comfort to avoid major pitfalls. Pain is a real problem, whether it's in the mind or it's real for the patient. Anything going in your rectum with a needle probe into the prostate is going to send some kind of fear among our patients. And up to 90% of men report some sort of discomfort during the truss-guided biopsy. And the cores drive the pain. Means if I want to take, say, a saturation biopsy or a 20-core biopsy, I need the patient to be absolutely still so that he doesn't move. And if he has pain, he will definitely move. And the pain comes from the firing of the needle into through the periprostatic fascia and the capsule. Now, is it easy? It is a very easy method. It's very simple and very effective. So why should we avoid giving this? We should ideally give it in all patients. So basically, which are the regions we need to anesthetize? There is something called as a Mont Blanc region between the base of the prostate and the seminal vesicle, the angle which forms. This is the region where the majority of the nerves are targeted. There is something called as a modified periprostatic block, where we go even laterally to the base of the seminal vesicle, to the tip of the seminal vesicles, and inject a few more mLs of anesthetic. Apex is again a very sensitive area, because it is very close to the voluntary muscle of the rhabdosphincter, and that needs to be separately injected with anesthetic agent. And if we are doing routinely a transperineal biopsy, we should not forget that anterior zone, if you're taking a biopsy from the anterior zone, also requires a separate block. So I'll go through each of a transrectal and a transperineal block. So in a transrectal, I think most of us do transrectal ultrasound guided biopsies in a routine practice. So patient is usually lateral decubitus. The truss probe is introduced. We first identify the prostate, the base, the seminal vesicles, both the sides, and all of our ultrasounds have a needle guide through which we can pass a 22 gauge needle under real ultrasound guidance. So the most important area to inject the contrast is at the base and seminal vesicle angle on each side. So 5 milliliters of 1 to 2% plain lidocaine to confirm a cloud or mushroom cloud lifting the fascia of the prostate on ultrasound. We do that on the other side, contralateral side also, and apical around 2 to 3 ml per each side on the apex. And because of our impatient, we usually go ahead and do the biopsy immediately. Ideally, you need to give 3 to 5 minutes. You can give a prostatic massage so that it is diffusely spread around to anesthetize the prostate. So this is a transrectal periprostatic block. Okay. Today I am demonstrating a transrectal prostatic periprostatic block. We are using the BK 5000 transrectal multiplanar probe. You can see there are 2 axial points you can see, and the biopsy guide which is attached already to the probe. And I'm going to use 10 ml of plain xylocaine on each side of the prostatic apex in between the prostate and the seminal vesicles to create the periprostatic block. So I'm just going to show you right now how we do it. So here you can see the sake of taking the video, I'm doing it under anesthesia, not as a routine. I'm coming from the bladder. You can see the seminal vesicles. This is a large gland. You can see the median lobe protruding into the bladder. As I come back, this is the base. This is the mid prostate. As we come down, that would be the apex. So if you see, there's a target line which is shown here. The advantage of this biplanar probe is you can visualize both the axial and the sagittal images simultaneously. So that helps us target the area very effectively. So you can watch the sagittal image, you can see the needle coming through. So I'm injecting the local, this is on the right side of the prostate. So you can see that is the angle between the seminal vesicle and the base of the prostate where I have injected the local anesthetic. You can see the local being injected. So I give 10 ml on one side and 10 ml on the other side. So you can see the needle again coming through. So I'm injecting another 10 ml to the right. Okay. So the periprostatic block is done. So a transperineal approach is little different because the tract goes through the perineal skin. So just a mere periprostatic block alone will not be sufficient. We need to anesthetize the skin too. So basically we do a skin and subcutaneous wheel initially. We infiltrate the deep tract. That means we can see the needle going through the layers of the muscle into the around the sphincter and till the apex of the prostate. Then the rest of the procedure is the same, where we need to target the base and the apex. And usually it's a freehand technique. But if we are doing it when we need a larger template, or for example, if our radiotherapists are suggesting to put seeds, radioactive seeds, then we would do it under general anesthesia with the stepper because it's more comfortable. So again, it's the same 5 ml per side, 2 to 3 ml at the apex, and totally of 10 to 16 ml total volume. The base injections are the primary targets, and apex is for full sensory coverage. So this is the transperineal periprostatic block. So that's the midline perineal infiltration being done. So you can This is up to the prostate in the midline where the local anesthetic is being given. So this is the apical part of the periprostatic block. So here you can see we have gone up to the base of the prostate. So you can see this is the bladder, this is the prostatic region, you can see this is the seminal vesicle and the anesthetist. Okay, so what is transrectal versus a transperineal block? The needle path is through the rectum in the transrectal, whereas it's through the perineal skin. The typical anesthetic is same, 1 to 2% lidocaine. Rectal wall involvement increases the infection risk. We have a separate session on that. Anterior zone coverage is limited on the transrectal, whereas it is easier on the transperineal. Is extra anesthesia needed? Usually a local block is sufficient. And usually, as I said, we have to wait for 3 to 5 minutes before we go ahead with the procedure. And any other adjunct techniques which we can use. One is intrarectal lidocaine gel. One is obviously counsel the patient pre-procedure so that their anxiety is relieved. We hardly use or never use oral angiolysis or sedation. And as I said earlier, if we are going through a saturation biopsy or we need multiple cores for transperineal mapping, then we would prefer a regional or a general anesthesia. Before we do the block, make sure you confirm the needle tip position before injecting the anesthetic. The subcapsular bulge as confirmation. Obviously aspirate before injecting to avoid any injecting the anesthetic into the blood vessels. And 3 to 5 minutes full wait time before the first core. And avoid forgetting the anterior zone coverage, especially on transperineal cases. And if you start the biopsy before the onset of the anesthetic, then the course obviously hurt. And now what is the evidence? So if there is, this is a visual analog scale of the pain score. So if you see no anesthesia at 7.5, intrarectal gel alone is 5.8, periprostatic block is almost half to 3.4, and if you use both together it's around 2.3. And the advantage of this periprostatic block is that complication rates like bleeding or infection are not significantly increased by just adding a periprostatic block. So if there are any questions, anything to be discussed, we can. Otherwise, I'll go ahead and we will discuss about the transrectal and the transperineal prostate biopsy. So now we have given the periprostatic block. So basically, once we have prepared the patient, we have marked the lesion, we have given the anesthetic, it's our duty to hit the mark. So I'll be going through briefly about what are the indications, anesthesia and equipment I have already discussed, the transrectal technique and the transperineal technique, and the safety of each. So common indications: elevated or rising age-specific PSA, suspicious digital rectal examination findings, PIRADS 3 or more lesion on multiparametric MRI, as part of an active surveillance protocol to see if the lesion has upgraded to a higher Gleason grade, and if the PSA is still rising after a prior negative biopsy. Choosing the route is optional. It depends on the experience of the person performing the biopsy, as well as institutional practices, whether some few institutions have only the transrectal probe. We don't have the transperineal probe. Infection risk profile is for a panel discussion, and most of the procedures can be performed under local anesthesia. I think it is mandatory. I think all of us can come to a conclusion that before we put the needle, it is imperative that we get the multiparametric MRI done. So pre-biopsy MP-MRI and PIRADS is a must to plan the number of cores and the route involved. Prophylaxis usually is a single dose prophylaxis. It could be because the antibiotic prophylaxis can be directed by your own local antibiogram. We usually use piperacillin tazobactam, a single dose for the transrectal route. And I don't think any of us do rectal swab cultures anymore, because this rectal swab cultures, I've just put it here because it was part of a trial study when they compared transrectal and a transperineal biopsy route. You definitely have to have a PT, APTT, INR before we go ahead with the biopsy, any biopsy for a solid organ for that matter. And if you have to do, you can bridge as per the bleeding risk, and preferably that time a transperineal route would be better than a transrectal route. Consent and counseling, again, very important in this era of medical legal cases being thrust on us. And we have to discuss the infection, the bleeding risk, the retention of urine post-procedure, and any route-specific risk differences. So I have already spoken about the periprostatic block and how it differs for the transrectal and the transperineal route. Equipment and setup, it's basically the same, especially for a transrectal we have, and the transperineal we have a biplanar truss probe. We usually do the biopsy with an 18 gauge biopsy gun. If we are planning for a multiple core biopsy, then only we will require a transperineal stepper, or a freehand needle guidance device is sufficient. And MRI ultrasound fusion platform. Ideally, it is better to get fusion targeted biopsies rather than cognitive biopsies for either route. So a transrectal, we do it in the OPD, in the left lateral position, a digital rectal examination with a lubricant. The ultrasound is used to survey the gland both in the sagittal and the axial planes. Block is administered, and through the guide we do a 18 gauge needle biopsy. This is a transrectal route. We usually perform a 12 core biopsy. We inspect for bleeding post-procedure and antibiotic course if indicated. And we usually ask the patients to void once in the hospital before they leave. So basically, if you see the prostate, if you're going transrectal, it's from behind. If you go transperineal, it's from front. So the number of biopsies can be as per the route. If you go transrectal, you go to the base, you go to the mid, and then you go to the apex. This is the transrectal route. If you do the transperineal route, you're seeing it straight end on. So you see it anterior, mid, and posterior. Okay, so there's a basic difference between the course what you take within a transrectal and a transperineal route, but it's not very difficult to understand because the probe is different. Here you're targeting it from behind, whereas in the transperineal targeting it from ahead. So that is what the difference is between a transrectal template and a transperineal template. So here I'm just going to show you a fusion biopsy what we did on the same patient. Now we'll go ahead with the fusion biopsy. Fusion image, please. Interesting thing about this patient was he had a 100 plus gram prostate. He had a negative prior biopsy. His PSA was around 11, and even after a year, after all the alpha blockers and the antibiotic course, it's still 11 and above. So we got a repeat multiparametric MRI, and this time we planned for saturation biopsy as well as a targeted core biopsy, because we didn't want to miss any lesions. And to our surprise, the saturation biopsy missed completely all the cancer, whereas we marked 2 lesions and lesion 1 was positive. So 1 lesion in a 100 gram prostate detecting a Gleason 3+4, I think is a big win for us, because otherwise this patient would have just gone ahead and got probably a TUR done or an enucleation done before we say that it is a benign prostate. So the advantages, you can see this, the contoured image is already there, the targeted image, the pink is the one which is a lesion which has been targeted. And usually we take around 3 to 4 cores from the lesion. So here there were 2 lesions which we have marked. Lesion 1 is the pink, lesion 2 is the blue one. You can see the diagrammatic picture where the representative diagram shows from where the biopsy has been taken. The advantage of the BK 5000 is you can see exactly where it has gone through the lesion in the below image down here. So you are sure that you have not missed the lesion on the biopsy. So transperineal is little bit more complicated than the transrectal. One, you need a lithotomy setup in your OPD, which many of us don't have due to probably space constraints. The probe is again introduced transrectally. I have told about the anesthesia which is required. You advance you systematically sample each around 12 cores. As I said, I told you the difference between a transrectal and a transperineal. So there are various biopsy templates. Each institution has its own. We usually follow this systematic transperineal biopsy protocol, where as I said, apex, mid, and base. So you have on each side you take anterior and posterior. So this is a transperineal biopsy technique. This is a freehand technique, because the software for a transperineal biopsy fusion is different than a transrectal biopsy fusion. So that is it's quite costly. So I'm showing you a freehand technique of the transperineal. So this is the right anterior. Two biopsies. It's not coming. Sorry. 2 biopsies each. Now we have the right posterolateral. Again 2. You can take additional lesions if you suspect that there could be a transitional zone lesion. The same thing is done on the left side. And if you do a grid style template, it's even more accurate and even more advanced, because each grid holes are only 5 mm spacing map, and using the ultrasound coordinates, you fix the grid first before doing the biopsy. It enables the true whole gland anterior to posterior sampling, but freehand is good enough for office-based cases. So head-to-head technique comparison, transrectal, transperineal, as the name suggests. The position of the patient is in a lithotomy position in the transperineal, usually a 12-core systemic biopsy. Infection risk we'll come to later, and transrectal is best suited for office-based cases, and transperineal for very specific anterior or transition zone lesions, and with patients who are at a risk for higher infection. I would not go through this infection and complication profile now, because one of the panel discussions we have is on transrectal versus transperineal prostate biopsy. So again, I would not go into the trials, but where the guidelines stand. Europe has moved away from transrectal and they've gone into transperineal only, to a point of saying that they should say that transrectal prostate biopsy needs to be thrown out of the window. Well, that is how strict they are. A recent ongoing trial is called the Translate trial, which is going on in the UK, Ireland, UK and the Scotland and areas. But if you see the American Urological Association, both transrectal with optimized prophylaxis and transperineal are accepted approaches. So this is a shift from the European mindset, and guidance increasingly highlights the infection risk advantage. That is a common thing which they say transperineal infection risk is lower than in transrectal. So practically the choice is being driven by local infrastructure, operator training and comfort and infection control priorities. So confirm the block, watch retention risk after transperineal, because there is significant discomfort for the patient following a transperineal block under a transperineal biopsy under local. So we make sure that the patient passes or voids once at least in the hospital before he leaves. Otherwise we may need to temporarily catheterize him. And apical lesions are common to be missed and is easily undersampled in either route. Whichever route you use, please document the exact target coordinates so that a positive core can be correlated back to the MRI lesion. So both routes sample the same gland. Infection risk is a big question mark, we'll discuss later. Targeted prophylaxis narrows the gap. Anatomy still matters. That means anterior and transitional zone lesions could be still better reached transperineally. So anything which we can discuss, we are free. We can take a break if there are no questions for tea, and we'll come back in 10 minutes time for the next session. No questions. Okay, so we'll break for tea. We'll be back in 10 minutes. Thank you. Thank you. So we have done the biopsy, and now we have Dr. Suneet, who is the head of diagnostics agilist here at Fortis Bangalore, who will be giving us a talk on how to read the prostate course after we have done the biopsy. Over to Dr. Suneet, ma'am.
Thank you so much, Dr. Karthik. Although I know, surgeons hardly listen to the pathologist most of the times, but I'll still try to, give my point of view as well. So we really have a very busy and a thriving department of urology. It's very difficult to tell you, but they put a lot of pressure on us when it comes to reports, and they are excellent in their job, and we try to, keep up with their demands day in and day out.
The TAT time for a biopsy is 24 hours. I don't think it's quicker anywhere else.
Thank you so much. Thank you so much. So, as a pathologist, how to help a surgeon? When the patient comes with a high PSA and they have done a 610 biopsy, so then they send us the biopsy, and then they expect the report to turn out in 24 hours. So as a pathologist, what do we actually look at? So once we get the biopsy, the main thing is to tell whether are we dealing with a cancer or no. Is it a prostatic CA, yes or no? If it is a CA, how aggressive is it? How much is it, and where it is? Because they'll be doing from left side, right side, apex, base, and the multiple sides. So whenever we get a biopsy, that is what we do. So first of all, when we look into the biopsy slide under the microscope, if there is no cancer, we obviously tell them that there is not enough proof of any cancer in the slide. Prostate, the beauty about prostate, it is always a bilayered glands, organ with a bilayered gland. So we have a basal layer, and then we have the acinar layer lining. So we have a couple of IHC like a P63, which lights up the basal layer if there is no cancer. Because sometimes there are a lot of mimics, like even an atrophic prostatic glands, they might mimic adenocarcinoma on a slide. So the best thing is always, take your time, put an IHC marker like a P63, go back to the surgeon and tell, no, this is not a CA, it's just maybe a atrophic prostatic glands, or, just an atypical acinar hyperplasia. Let's follow it up and keep on observing the patient. So that time, it's the urologist's take. They have to correlate with the PSA kinetics. They have to do an MRI and probably plan on, if they still have a suspicion, they will always go for a repeat sampling. What about chronic inflammation? Chronic inflammation also, can create a spike in the PSA levels. We see very often granulomatous inflammations or chronic inflammations which spike the PSA level. Free PSA comes in handy those times to distinguish between whether it's actually really because of a malignancy or maybe because of an inflammation. Again, post-BCG granulomas are sometimes quite common, and there can be some other reasons. So again, go back to the urologist, tell him again, no cancer, please keep a follow-up. What about lesions which are not invasive but just a high grade? Prostatic intraepithelial neoplasia, that is what we call as a high-grade PIN. They can be precursor lesions. You might pick up a foci in a prostatic core. Definitely inform the surgeon, yeah, we have picked up a high-grade PIN, but we didn't see a CA there. So again, it depends. Based on their MRI and other PET's findings, they will take a call. Again, the atypical gland, suspicious but not diagnostic. Again, IHC is very handy to distinguish the both. Again, they can repeat a biopsy, probably targeting the same site, and see whether those glands have changed anyway in their aggressive nature, or are they the same. And finally, an acinar adenocarcinoma, once we pick it up on a core biopsy, the next thing is to always risk stratify with the grade, extent, and the staging. So I think many of you who are practicing urologists, you must have come across these terms, the Gleason's grading, and again the grade grouping. So in pathology, the most important thing which we look into when we see a prostate biopsy is the Gleason scoring. Gleason, they have given a scoring based on the architecture of the glands. So when we see the small round tubular glands, just to tell you, on the extreme right, it's a benign tissue, extreme left. And in the center, we have prostatic, which is Gleason grade 3. So if you see the glands, they are quite uniform, they are well rounded. And as the score keeps increasing, in Gleason 4, you will see the glands will be more angulated. In Gleason, then some cribriforming will come. Maybe hyper clearing of the nuclei will come. Then there is Gleason 5, where the cells will become single, and they will start roaming around freely in the prostatic tissue. So that is the grade 5. That means they have become more aggressive in nature. So based on the biopsy, we try to tell, once we diagnose, okay, this patient has a prostatic adenocarcinoma. Now, what is a Gleason? So Gleason, what do we do actually? We take which is the dominant pattern and which is the second dominant pattern. And then there can be a tertiary pattern which is only less than 5%. So suppose there is a case where the pattern 4, like the cribriform or angulated glands or fused gland pattern, let us say was 60% of the tumor. So we say 60% is Gleason 4. And which is the second dominant pattern? Let us say it was a 3, which is, let us say, was 35%. So we say it becomes 4 plus 3. And less than 5%, if we find, okay, there is some single cells roaming here and there, so they might represent pattern 5. So we say, okay, so less than 5%, we saw a tertiary pattern as well. So based on that, we give something called as a grade grouping. So these are all just the patterns. So the pattern which comes first, like if it is a 4 plus 3, which gives you a score of 7, that means 4 is a dominant pattern and 3 is a lesser dominant pattern. When we say 3 plus 4, we say the 3 is the dominant pattern and 4 is a lesser dominant pattern. The total is 7 for both. 3 plus 4 is also 7, 4 plus 3 is also 7. But here the problem is, when you say a 3 plus 4, you put it under a grade group 2. And these cases are actually, even they can be just taken care for only active surveillance. And if a patient is old and he does not want to get operated, you can still give him a chance. Maybe you can say that, please be on a continuous active surveillance and we will again come back to you. You just can keep doing a monitoring, if the patient is an inoperable case. But when we say it is a 4 plus 3, in that case, you need to treat the case. So I think this is one thing which I would really recommend that everybody who is practicing urologist should know these grade groupings. So you have 3 plus 3, which is a grade group 1, which actually don't require anything. They can be just put on active surveillance. They're ideal candidates. 3 plus 4, 7. Surveillance is possible depending on the percentage of 4. If I say that percentage of 4 is 45% and the percentage of 3 is 55, probably you can still look at it as an operable case. But if the percentage of 4 is hardly 5 or 10%, probably you can still put him on an active surveillance. 4 plus 3, definitely that case will behave worse and you need to take him up for a surgery. A grade group 8, which is like a 4 plus 4, definitely you have to treat the case. And maybe a multimodal planning with maybe the other whatever. I think Karthik would be the best person to tell what all extra things they are giving. And again, 9 and 10 are high-risk cases. So there you need a staging, imaging, and do whatever is required from the treatment point of view. Another thing I would just tell you is that a lot of emphasis is now being given to the cribriforming pattern. So whenever a pathology report says that we are seeing a cribriforming pattern and a component of an intraductal carcinoma, that time it changes because they have been, whenever studies have been conducting, when they follow these cases over a long time, they do little bad. So knowing your pathology report is very, very important. Please see all these things. Look for whether the pathologist has mentioned about a cribriform pattern. Has he mentioned about an intraductal CA? What is the grade group he has put the patient under? Then what else can we look for? We should be looking into something called as a perineural invasion. That can affect the prognosis of a patient, and extra prostatic extension. But unfortunately, most of the time on core biopsies, we don't see that. That is more evident when we get a radical specimen of a prostate. So it's on that time we can tell you whether there is an extra prostatic extension or no. But usually on a biopsy, that is not something we can tell. Sometimes lymphovascular invasion, maybe we can see sometimes on a core biopsy, maybe we can tell you that also. So what is really important is the Gleason scoring, the grade grouping, the percentage, what is the dominant pattern, then how many cores are involved, again whether the right is involved, left is involved, how much is the millimeter area that pathologist is telling, is the 20% of all the cores involved or 50% of the cores involved, that also has a prognostic significance. And besides that, as I told you, cribriforming architecture, intraductal pattern, if it is picked up on a biopsy, all these things are very, very important when you take up a patient and tell him whether he needs further surgery or no. The report, if it's what can help you to get a better report, as I told you, a serum PSA density, digital rectal examination findings, obviously on the request, if all these things are available, definitely a pathologist can give you a better report. MRI report, if at all is available. At our hospital, they are very excellent in their practice and they give us all the information beforehand. And a clear labeling of the targeted versus a systematic course. Any prior biopsy report findings are there, so that also, if it is mentioned, definitely helps the pathologist, give a better report. Clinical history of a current or a previous hormonal therapy or a radiotherapy, any germline mutation or any strong family history of prostatic CS. So even if, sometimes eyes cannot see what mind doesn't think. So if some information is already available, maybe if there is a small foci which can be missed, there will be a more degree of suspicion while we are examining those slides. So definitely all those things matter a lot when it comes to a pathologist, how do they see the slides. So 5 lines to read first is a diagnosis, whether it's a cancer, it's just an atypia or a benign. What is the grade group? What is the percentage pattern of 4? Because that's the most dominant pattern which will decide which way, whether it will go for a surveillance or a surgery. The extent, how many cores are involved, percentage of the core, the millimeter, the cribriforming pattern, and the intraductal carcinoma component. And that is how you should go by the report. This is how we do the biopsies in our lab. Once the sample is received, along with the core orientation and the proper history and everything, we do a formalin fixation. The samples are processed, and we do the staining, and IHC is done wherever required. Nowadays, brilliant IHCs are available. MCR is there, NKX 1.1 is there to confirm it's a CA. P63 is there to rule out if it's just a benign case. So we always do this, and after that we give ISUP grading, the Gleason grading, the tumor extent, and whatever the adverse features are there. Thank you so much for your patient listening. I'm open to any questions. Thank you, Dr. Karthik.
So, any questions? Yeah. Please go ahead, sir.
Normally we tell that, but it all depends on how many, what is the clinical suspicion, what is the PSA, and also, whether the sampling was good enough.
But the PSA has a role before advising the surgery.
Yeah, but PSA definitely has a role, and most of the time, what our institute practices, they do a free PSA and a total PSA. That gives a much better idea. So PSA definitely is having a role. That is, we cannot rule it out. That's what, sir, like P63 if we do, it will highlight the basal layer, and it will tell us that this is a benign, it is only atypia. So maybe these cases have to be followed up, just like a breast case. We tell them that, this is just a hyperplasia or adenosis, but these patients have to be kept in active surveillance. Thank you. Thank you.
I have one question, ma'am. How difficult is it to means intraductal carcinomas and acinar carcinomas, except the glandular pattern? Anything else? Any difference?
The intraductal carcinomas, they are like the salivary tumor, so they become like a large ducts with some necrotic material in the center. So that is how we can make out. Whereas an acinar carcinoma will always retain the typical acinar pattern of the small gland-like proliferation, whereas intraductal will be larger, bigger in size, with like a ductal size bigger, and the necrotic material in the center. So it's, for a pathologist, it's a cakewalk.
Yes, sir. Please go ahead.
So, I mean, whenever I think any patient comes to our hospital, the standard practice is that they do a total PSA and a free PSA together. Because what we have seen is, like, many of the time, all these infections also, they will spuriously raise the PSA levels. So if you just go by a total PSA, if I'm not wrong, Karthik.
So between 4 to 10, again, as I said, the gray zone, we ask for a total and free PSA. If the total PSA is beyond 10, 15 and all that, I don't think there's role for a free PSA. So percentage free PSA between 4 to 10, anything less than 20% is still suspicious for us. Yes, yes. If needed, we ask for a percentage free if there is a doubt, yes. But I think in the role of, if you have a multi-parametric MRI, I think we go ahead with a multi-parametric MRI for in the gray zone. Before we, previous to the multi-parametric MRI, I think free PSA had a good, percentage free PSA had a very good role. But with the role of the multi-parametric PSA, with the multi-parametric MRI, the role of, I think, the percentage free PSA may be a little going down, yeah. Between 4 to 10. Total PSA between 4 to 10. Yeah, please go ahead. Please go ahead. The surveillance, actually, if you see the guidelines, if you see only the grade group 2 or less are for active surveillance. When they go it for a 3+4 may still go in for active surveillance based on the patient's wish. But
And also a percentage of 4. Means even 3+4, if the percentage of 4 is substantial, you can still, and if he is an operable case based on his health condition and comorbidities, I think they can still go for a surgery.
yes. Basically, I think active surveillance is more in the European countries and in the United States. In our part of the world, I think active surveillance is very difficult. One thing is because following up the patient. Second is compliance of the patient for repeat biopsies, and obviously the cost factor when you add multi-parametric MRI and then repeat biopsy, all the cost factors. And basically, I think we are a race which is more anxious when somebody hears the word cancer. So they would as well get rid of it rather than keep thinking that there's a time bomb coming here which is waiting to, correct, yeah.
The surgeons know the best.
Yes.
Yeah, maybe.
Okay, if there are no other questions, we'll go ahead for the next panel discussion. Thank you, ma'am. Thank you. So we're going to discuss whether MRI fusion should be the gold standard for prostate biopsy. So first I will invite Dr. James from Ghana, who's graciously consented to be part of the panel. And anybody else who would like to be part of the panel, please come. Because it's going to be a two-way discussion. There is no right, no wrong answer. Please. You're going from there. Okay. So I invite Dr. Shakir. Dr. Suraj. Dr. Shreyas. And Dr. Santosh. He's our main man for today. But you'll not be seen, sir. Come. So for the audience, I would like to request our panelists to just introduce themselves so that all of us know who they are, including whether urologists, radiologists, whatever. Please go ahead, sir. I start with Dr. Suraj. Everybody knows he's already given a presentation. So I'll start with Dr. Shakir over there.
Good morning, everyone. My name is Dr. Shakir. I'm part of Team Urology, a proud member, and one of the oldest in the team, just after Dr. Mohan. I've been with the team and evolving with the team through robotic surgery, through MR fusion, and enjoying technological ease as time goes by.
My name is Jay Mins, Associate Professor of Urology from Ghana. I've been managing prostate cancer since 2003.
Wow.
My name is Dr. Santosh. I'm in Fortis since the time when Fortis started in 2007. So now I head the department in Fortis. My specialty, one of my specialty, of course, is uroradiology.
Long vintage.
I am Dr. Shreyas. I'm a senior consultant urologist working with the Fortis for the past 8 years.
Right. So now that we have all introduced ourselves, we'll jump into the topic. The question is MR fusion the gold standard for prostate biopsy today? So as we went earlier, that historically prostate biopsies were guided by digital rectal examination and systemic sampling. Transrectal ultrasound improved the guidance but still missed significant amount of tumors. Systematic sampling is again only through the anatomic pattern, because as I said, 60-30-10 rule still holds. Only 60% of the lesions on ultrasound are hypoechoic. So this unmet need in prostate visualization is why MR fusion was designed. So we'll just go through the questions initially. First, a show of hands. How many in the audience perform prostate biopsies, even if you're a radiologist, urologist, anybody? So how many in the audience perform prostate biopsies? Oh, wow, that's a good number. Now, that's a tricky question. How many of us refer to our radiology colleagues? Good. We have one hand, we have two show of hands, and we have the third. You can as well refer to urologists too, sir. Understood. Right. So, sir, do you feel that there is a difference when an interventional radiologist targets a lesion rather than a urologist targeting a lesion? I will ask the question to both, to the urologist as well as the radiologist.
No, I think in terms of reading the scan, I think we radiologists would score over any other person.
Totally agree.
Yeah. So that's
Totally
because we've gone through, let's say, all of us would have trained from ultrasound. We have done a lot of trust biopsies earlier when we were doing in college, or let's say in training or anything. Then we've moved to MRI. So we are always, I would say we are very good at MRI. I won't mince any words. I think we would be better than any clinician in reading the MR. And I keep telling my juniors that we have to be better than the best, because nowadays most clinicians will be very good reading at their images. For example, neurosurgeons or urologists.
I agree with you totally. So
we are always trying
average radiologist can read an MRI 10 times better than the best urologist. Yes, totally. No two terms.
So coming to the biopsy part, I think urologists would be in that sense better, because partly better because he is now aware of the whole clinical situation, which we are actually not aware.
Correct.
Let's say the PSA or the
Understood.
DRE or the clinical profile and all that. We are only given a patient.
Correct.
For example, like a pathologist, she is given only a piece of the tissue. So we are given the patient with a image. So we are likely to target more like a good at targeted biopsies than more like a systematic biopsy.
Excellent.
So I think I mean,
Yeah,
in
we got
terms
the-
of both, I think
Yes.
it's.
Any of the urologists would like to put a word into it?
Oh, I think in terms of identifying the lesion, they are clearly better than
Okay.
us. But for us to do a targeted biopsy, we should trust the target they've given us. That is where the challenge is.
That requires a round of applause. So he hit the nail on the head. He said that the radiologist have to give you a lesion for us to target. So that I think is the whole point here, which I asked this question, because it's always a combined effort. It is not a effort alone individually. So yes, targeting lesion is better by targeting the lesion is better by the radiologist. And yes, since we have more clinical picture, the urologist, I think the number of biopsies being done by urologists far exceeds the number of biopsies being done by radiologists. So in that way, I think lesion targeting by the radiologist and performing the procedure per se by the urologist should be, I think, a common concern or common consensus with the panel. And I have one person who begs to differ.
One thing is, it is always better if the MRI is interpreted by a radiologist who is pretty experienced with regular reporting of these MP-MRIs. At times what happens when we write for an MP-MRI, patients go out of Fortis or out of that place to a different CT scan center or an MRI center and get the investigation done. So the problem here is we cannot discuss with the radiologist over there if we have a suspicion on some lesion when we see through the images. And second, sometimes the imaging center or the radiologist there would not be that experienced reporting an MP-MRI. So that would be difficult in marking the lesion and also identifying it.
No, the second thing, what I followed as the head or is that every scan is monitored. So every scan I monitor, or not only the prostate scans, most scans at least, we monitor to such an extent that we stick to protocols and we follow everything. So when we follow and we do those scans like what we want, then I think the quality should be better. Not like somewhere, most scan centers where the technician scans and the radiologist either reports from the center later or they do a teleradiology reporting.
Yes.
That is what I wanted to highlight, sir. When they go out, we don't have a control over it.
Now, just to kind of sum up this, essentially the radiologist sees life in grayscale, and so they're way more experienced than any of us. That's clear. And when they mark on an MR, because MRI is fused onto the transrectal ultrasound. So the images are taken from the MRI, marked by the radiologist who's way more experienced than us. The only onus on the urologist is after that, when they receive the biopsy report, we are the one who's talking to the patient. So whether it's going to be a positive where we have to talk about the surgery, or it's a negative where we spend a longer time explaining to the patient why their PSA is high but their biopsy is negative.
So the new point here is that as per Dr. Suraj, we need the radiologist to be in-house so that everything is as per protocol before we say that yes, the radiologist's findings are better than what the urologists see, right? So I think that settles the issue. The next question to Dr. Santosh. Could you tell us what specifically would be the difference between doing a MP-MRI prostate using a 1.5 Tesla machine and a 3 Tesla machine? Obviously 3 Tesla machine is better. I just wanted to ask how better?
I won't say it is, 1.5 into 2 is 3. It is really not like twice better or anything. But then because it's a higher magnet, you have better soft tissue contrast. The scan times are reduced, not really in terms of half the time of what a 1.5 would, but given the increased magnet, this one also gives you a higher resolution. For example, 1.5 Tesla, we were earlier doing it at, let's say, about 256 matrix. Means if you take a square, you would have 256 into 256 pixels around. On a MR, now we are planning and almost doing 512 matrix. So you can imagine the kind of resolution which is there. So you are likely to pick up more, sub-centimeter size lesions more often. the extra prostatic spread also more often. So obviously the intrinsic resolution is extremely good, and therefore you can actually reduce the field of view, which would further increase your intrinsic resolution.
Can a multiparametric MRI be done in, say, we have something called as an open MRI?
No, that is one thing. Open MR is only for marketing. It's only about a 0.5 or a 0.3 Tesla.
Okay.
So we can't really do anything.
Layman's question, sir. Okay. Yeah. Now, listening to Dr. Santosh, I know it's put in one package, but how many of us are comfortable now reading a multiparametric MRI of the prostate? One for my sake. Yep. You can lift your hands. Show of hands, please. Who are comfortable reading a multiparametric MRI? You can lift it, even if it's half. It's okay.
No, because I'm using it for the radios.
Excellent, 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 excellent. Okay. I think our goal is almost almost aligned, because if 5 or 6 among us can read a multiparametric MRI and then mark the lesion ourselves before it comes to you and get a biopsy done, I think in peripheral centers where they don't have the expertise, that goes a long way. So you have helped us really by coming us and giving us an excellent presentation on how the lesions differ, especially when you see prostatitis and you see prostate cancer, the subtle differences. We may not be able to say whether it is pyroids version 1 or 2 or 2.1, but at least I think I can mark that there is something wrong here. I think that should go a long way. Yes, any comments?
I'll just introduce myself, Dr. Kim Karan from Mauritius. I'm a head of clinical oncology in my setup. So where would you fit in a PSA PET scan in the along with the
Okay,
parametric
can I take the
MRI?
question?
Yeah, sure.
Okay. His specific question was, where would we place the PSMA PET CT when doing an MRI? I think for a local staging, still multiparametric MRI is significantly better. But for a systemic, I think PSMA PET CT holds a bigger PSMA, and yes, so there we have you can say in quotes, we have a PSMA MRI also, not only a PSMA PET CT. So we have a PSMA PET MRI. That would be, I think, the best. But yeah, go ahead, sir.
Just to be on this one, no, I mean, please don't take it otherwise. I mean, we used to make fun of nuclear medicine as unclear medicine. Okay, so I mean, I'm not this one, but the resolution, the soft tissue resolution or the anatomical resolution is inherently poor on nuclear medicine. However, it is very sensitive also to a specific also. So when you combine nuclear medicine with CT, the resolution is better. Let's say from, it moves ahead, the resolution moves ahead and it becomes better. But when you combine a nuclear medicine with MRI, like what Dr. Karthik is telling, it moves even further. So I think maybe the way forward, maybe in the future, combining a PET with an MR has its own inherent problems. Like here in Bangalore, we have one place, but it's not doing, in that sense, it's extremely difficult. There are a lot of logistic, not only logistic, lot of inherent contrast issues and other things. So when we do that, it's always there is a lot of challenges when we do the scans.
I think the PSMA PET CT, I attended the 2019 AUA, and I was shocked that a patient having insurance in United States had to wait 6 months to get a PSMA PET CT appointment. And once he got a PSMA PET CT done, it's almost sure that he will never get another appointment. It is that bad. But in our place, like Sir said, I write morning PSMA PET CT. On the OPD, it gets done by evening. So it's evolving. It's evolving. Yes.
Prostate, you have to see the clinical scenario where the DRE shows that there is some sort of prostate involvement which is beyond the prostate and it might be a rectal involvement or into the perirectal tissue. Other thing is the PSA levels you have to see if it is beyond 20 also, and the MP-MRI shows that there is a localized lesion. Then the suspicion of metastasis is more. All those situations also you have to consider to do a PET CT, not alone the MP-MRI to decide on the plan of management, because the higher PSA levels also will tell that there might be a metastasis if the lesion is seen localized in the...
means agree, totally agree. There will be multiple this one. You have a perineural spread on the biopsy, you have a Gleason's score of 3, 4 and 5.
Score on the biopsy report. All those things also has to be considered.
Done. So, so the last question, because we have discussed the other two, is inter-observer variability. With obviously more training, the inter-observer variability among radials is going to go down. And sir has already answered the next question with raised creatinine levels. We can still go ahead with doing a multiparametric MRI. So among all of us, if a patient's MRI is negative, suppose with a PSA of 6, would you be comfortable to skip prostate biopsy? First to the panel, then to the audience. Show of hands who says they would be comfortable to skip a prostate biopsy if the MRI is negative. Show of hands to say they would skip a biopsy if the MRI is negative. PSA 6. I said first to the panels, then to the audience. Skip, okay?
With the free percentage PSA also being a factor.
I am not giving you anything else. I am saying 6.
I want that before I do an MRI.
Okay, done.
No, in our environment, Africans have a higher risk.
Yes.
And also the family history.
Excellent. I was about to come to that, but then he's already taken away the mic from me. Because when I said 6, he obviously says that, oh, it's a red herring for me. It doesn't hold good. But in our setup, with a lot of prostatitis going around, when I say 6, Dr. Shakir is already also right when he says, I would want a percentage-free PSA before I ask for anything else. So the question was basically meant to ask if the MRI is negative, are we comfortable to skip prostate biopsy? As of now, probably requires more validity and more other factors like you rightly said, like the race, ethnicity, family history, the percentage-free PSA and other questions.
The MP-MRI is advised only if these hold true. So there won't be an MP-MRI if this was not the case. For example, if it was a 6, as you rightly said a while ago, it's in the gray zone. If it's in the gray zone, we don't immediately go for
That's what. That's another controversy for a different panel discussion. Like if I have a 6, I would like to go directly with multiparametric MRI before I ask for a percentage-free PSA. Yes, it may differ with different urologists and this one. Why? That's what. It's a different panel discussion altogether. We're not going to go there. Yes, right now this is not yet fully answered. So we'll just go briefly. So we have 4 studies who have shaped this evidence so far. I've already told you about the PROMISE, the PRECISION, the MRI first study. So basically it says multiparametric MRI has twice the sensitivity of trust biopsy for significant cancer, and 25% could have safely skipped the biopsy if it was MRI targeted. The PRECISION trial again said significant cancers were better detected by MRI targeted biopsies, and indolent cancers were less. MRI first study had targeted versus systemic, and this actually combined both and said if you combine targeted as well as the systemic biopsies, the rate of clinically significant cancer detection is even more. So this is still an ongoing study, again in the UK and France. So its MRI based pathway is non-inferior for significant detection of cancer prostate. One important point is fewer biopsies, fewer biopsy cores, and less overdiagnosis at the population scale. So bottom line, multiparametric MRI before biopsy, first biopsy is, I think all of us would agree. Before we perform a biopsy, yes, I have a different view.
Yes, not for every patient.
Not for every patient.
If a DRE shows a T3 or T4 lesion, we will not do an MRI.
Excellent. Yes.
You're just wasting the patient's money.
Okay.
We'll just go ahead and do the biopsy and rather do a diffusion MRI for staging.
Very good. Now, the questions that still remain open. Can targeted biopsy safely replace systematic biopsy in all cases? Maybe not. How reproducible is MRI interpretation outside expert high volume centers? Still requires further validation. And when we do all these, actually do these diagnostic gains translate into really long-term survival for the patients? So these are the questions that remain open, will be answered, say, in a few years' time. And thank you for a very, very, very vibrant and very enthusiastic discussion in the panel. And if the panel gives me the permission, we'll go into the next. Okay. Yeah, please go ahead, sir. Sorry.
Patient comes with a little bit of bloody, what do you call it, a semen coming out after ejaculation.
Yes, sir.
And his PSA level is below 1.
Okay.
And ultrasound shows on an enlarged prostate of the size. They usually give it in grams, something like about 50 grams.
Okay. So
and nocturia, only one time he gets up in the night.
how old is the patient, sir?
He's around 65.
65. So
how to go about it?
excellent. So I think that's an excellent question, which very common scenario. Any of them who would like to take it? Dr. Shakir, Dr. Shreyas, Dr. Suraj, anybody who would like to take this question, please? A 65-year-old gentleman, I'll just concise, 65-year-old gentleman with a normal PSA, hematospermia, 50-gram prostate on ultrasound.
So one thing which we have to take into consideration is a prostatitis. When a person presents with symptoms of blood in semen. So what I would suggest is treat him with a course of antibiotic first, see whether his symptoms will improve, and if it improves, good. That is mostly we think it is in favor of prostatitis. But in case if it doesn't improve, then we will think about what are the other causes which we think. So let us keep the common causes first, thinking of prostatitis first, and treat him. And later maybe we can evaluate if it keeps recurring to what exactly is happening. So from a physician point of view, I think better treat with a course of antibiotic, follow him up. If it still recurs, then you can come back. Semen culture is one option. But I think basically you can treat him and then refer if it recurs back. Yeah.
In this particular patient, I would not rush up with an investigation with a cross-sectional imaging at the first. See, considering his age, 65-year-old man, and the most common cause for one episode of hematospermia is usually long duration of abstinence of intercourse or ejaculation. So that itself will tell that we can wait and watch. And PSA is on the lower side. He's in the age group to develop enlarged prostate, and he might be on blood thinners. All of that have to be taken into picture. So that could be the reason for this hematospermia. If all that is left apart, if a simple urine routine or a urine culture, if those are negative, then a semen culture. If semen culture is negative, then probably think of other pertaining things and evaluate further after that, sir.
So you made their life easy by saying PSA is 1. You made their life very easy. Excellent. Yes. Very good point, sir. Okay. So we'll go ahead with the last discussion for today. Transrectal versus transperineal prostate biopsies. Do we have clarity? And a short review of any contemporary evidence. So many of us perform prostate biopsies, so obviously that question is out of the window. Now, how many of us do transrectal route? Quite a few number. How many of us do a transperineal biopsy? Right. So, with the show of hands, what I wanted to say is, although transperineal biopsy has been vociferously supported, vociferously put around in all the guidelines. In any conferences you go these days, especially urological conferences, there are not many of us doing transperineal biopsies. Why is it so? Not that maybe we don't want to do it, probably want of equipment. Not many people have a transperineal probe because the hospital can afford one transrectal probe. They can ask you whether you want a transrectal or a transperineal, and most of us are very comfortable with the transrectal probe. We said better give us the transrectal. Few centers like ours, we are lucky to get both the transrectal and the transperineal, so we are more comfortable. Second, if there is equipment on outpatient procedure where the patient can be placed in a lithotomy position, then again many of us, if we have the facility, we could go ahead and do a transperineal biopsy. So with a show of hands, I just wanted to say that all of us are capable of doing both, but for want of few certain things, only 2 of us have raised our hands doing a transperineal biopsy. Okay, so the next question is to Dr. Subudhi. What is your major concern while performing a transperineal prostate biopsy? One is instrumentation, and he said anatomy is not very well versed, not used routinely. So these are the 2 concerns. Anything else? Pain. Okay. Means pain you feel is more in transperineal or in transrectal? Transperineal. Okay. So that is the major 3 concerns while performing a transperineal prostate biopsy. So basically, if you have equipment, if you have better training, you would also go in for a transperineal biopsy. That's what you mean? Okay. Okay, that will come to later. Yes.
And the concern of transperineal, the benefit, one significant benefit is reducing sepsis or infection.
I have not yet come to it.
I didn't even know you had.
Yes, I have not come to it. What is your major concern now regarding a transrectal prostate biopsy? You do have no concerns with a transrectal prostate biopsy.
One thing is the access through the root. If a patient has a fissure,
Okay.
access to a transrectal will be painful.
Excellent.
A prior history of any rectal surgeries, any
Excellent.
APR or rectal surgeries,
Excellent.
again an access will be difficult.
Excellent.
Those 2 will be the major concerns which I feel will be difficult to.
I am happy he didn't bring about infection. I am happy. Not for anything else, we just for discussion's sake. Yeah.
And on the transrectal route, it is difficult to target apical lesions and some of the deep-seated transitional zone lesions as well. So
Okay.
The advantage of a transperineal.
Okay. Okay. Now I'm coming to the specific question of infection rates, whether in transperineal or transrectal. Retrospective studies, yes, 1% transperineal, around 6 to 9% transrectal. I'm giving you the rates. So would it influence your approach to perform prostate biopsy? Infection alone, no other criteria, infection alone. I'll start with Suraj, whether he would, whether it will influence your approach to perform prostate biopsy. I don't want answers yes or no, that's it. No, excellent. Shreyas. No.
Yes.
Yes. Okay, it's easier. How many for yes and how many for no? How many for yes? How many for yes? Only 3. Good. 4. I'm sorry. How many for no? Oh, majority. I think they have read my slides earlier. Anyway, so basically what the question was meant, yes, there is significant risk of infection all this one were retrospective studies. Nobody has, only recently we have done prospective studies to compare a transrectal versus a transperineal biopsy for a specific purpose of infection rates. I will come to that. So it shouldn't influence your approach to prostate biopsy is what I'm telling you.
So this question, when you're going theoretically, according to retrospective studies, 1 and 9%. As clinicians, we know one patient of yours going into sepsis can make your next few months a nightmare.
My next question. Follow up to your question. Same thing. How many patients on whom you have done transrectal prostate biopsy have come back with serious sepsis requiring admission?
So this happened as recent as 6 months where it wasn't my patient. So I have advised him to undergo a transrectal biopsy. For reasons best known to him, and we have prophylaxis which is standardized. So we haven't seen sepsis in forever. So I'm confident. But he got it done in a center outside. He came back with sepsis and said, what you advised put my father into sepsis.
Yes,
that's
a
what
very
I'm
valid
talking.
point.
That is something you have to think about.
Yes.
But that doesn't take away. See, I'm going theory with
my question was specifically meant not to go
only
ahead
because
with
of the sepsis. Yeah.
with the infection rate alone. I'm not looking at the lesion, where is the location of the lesion or anything like that. I'm just looking at infection risk versus transperineal versus transrectal. Would it influence your approach? Yes. So we'll come to later why it could be or it should not be. This is, I think, an easier question. Which procedure would you believe is more cost effective? Anybody for transrectal? All of us for transrectal. All of us for transrectal. Okay. Do you give any anesthesia while doing prostate biopsies, whether transperineal or transrectal? You can use the mic. You don't have the mic. I'm sorry.
For the transrectal, no, unless the patient really requests for it or too anxious about it. For transperineal, always yes. Either in the form of a local periprostatic block or general anesthesia.
Yeah. Any other?
I didn't hear you. That's transrectal, no anesthesia.
Transrectal, no.
Transrectal.
Yes.
So I'm asking
no
you.
Local anesthesia.
That's what I'm saying.
Locally
What
in
I'm
the
asking
form of
is,
a jelly, sir. That is more placebo than actual anesthesia.
I see.
No. This is a it's a discussion. Okay, so his preference for a transrectal prostate biopsy, he doesn't use any form of a periprostatic block, if that's what you are coming into. He's not using periprostatic block. For a transrectal and for a transperineal, he says he requires local anesthesia. Any point differing to this point?
Because we have abandoned the rectal gel because we found that it was ineffective. So we do periprostatic blocks.
Good.
But for transperineal, we still do either caudal anesthesia or general anesthesia, not periprostatic block.
So that point was I have already made in my presentation to say that because if you do a transperineal biopsy, we do extended core biopsy, or if we have the benefit of having a stepper, we can do a template biopsy which requires significantly more number of biopsies. So preferably to be done under anesthesia because patient would be very, very comfortable. Yes. So the intention for asking this question is that transrectal biopsy can be done even without anesthesia. Local periprostatic block, without local periprostatic block, we can still do a transrectal biopsy with minimal discomfort to a patient. So that was my intention of putting this question there. Next is a theoretical question. Detection rates for clinically significant cancers, any difference between the two? If you do a transperineal versus transrectal, are there any changes for detecting clinically significant prostate cancers? For apex, both are equal. I rest my point there. For apex, both are equal. Whether you do a transperineal or a transrectal is the same. Only for the Only for the anterior fibromuscular stroma lesions where the transperineal is a better or superior modality. Okay. How many of us have had patients having post-procedure retention of urine following a prostate biopsy? We have one show of hand. We have quite a few show of hands. Okay. Because there are very few people of us doing transperineal biopsies, so the next question can't be asked because we don't have enough experience of transperineal persons performing transperineal biopsies or the number of patients to say whether urinary retention rates are more in a transperineal route versus a transrectal route. Okay.
It is definitely more than the transrectal.
Excellent.
Because
okay.
of the type of transperineal that we do. We do template
yes.
transperineal, despite the target that you've given us, because we want to build our own database.
Okay.
Yes. So we do templates, so the retention rate is definitely higher than transrectal.
Yes, that's what he's saying.
Yes. One, you see, the needles go quite close to the urethra, so the edema is more significant. But when we are doing transperineal, we routinely catheterize the patients so that we can clearly identify the urethra for the for the targeting.
Correct. Yeah. Correct. Okay. So
in this case, when you do catheterization, after how many days of the biopsy you remove the catheter?
The evening.
But you told there is a risk of retention.
Yes, so the evening. So when you take the catheter out, you have to void before you go home. So when you take it out, sometimes they fail to void. So we leave the catheter in for about 2 weeks.
Dr. Subodhi, this one of definition of retention is during procedure, post-procedure, because he's in anesthesia, they catheterize the patient. Once before discharge, they remove the catheter and ask him to pass urine. If
during the discharge, once the catheter is not able to pass,
then you do the
No. Before the patient came for the biopsy, he was voiding freely. We passed the catheter to identify the urethra for the. Immediately after the biopsy, the catheter is taken out for him to void before going home. Those patients, quite a lot, fail to void, especially if they are on finasteride or tamsulosin before the TP biopsy. Oh, I'll put about 10%. It's quite high. So high that we cancel the patient.
Done.
Yes.
So, pre-2024, the narrative, transrectal approach was the default. Then this Trexit 2020 came. I don't know from where it came, but it gave a significant, it's very strong terms to use, that you need to completely abandon the transrectal route. This was in Europe. Now, as I said, cohort studies, meta-analysis, lower infection, sepsis risks, better anterior detection with transperineal biopsy. All these were retrospective analysis. So, by the early 2020s, many centers had shifted to a transperineal biopsy on the basis of these retrospective analysis. Now, I'll come with level 1 evidence. So, in Albany Medical College, USA, a very specific study called as a PRO-PC. So 840 men, cancer detection and complications. A perfect trial done in France, 270 men, MRI targeted biopsy detection rates, and a prevent trial, 658 men, infection rates as a primary outcome. Okay? So all three were designed specifically to answer, does transperineal biopsy actually outperform transrectal, or whether the retrospective studies just overstated the difference. So in PRO-PC, if you see, transrectal 384, clinically significant cancer detected in 47%, and in transperineal 43%. So my previous question was, clinically significant cancer, is it better in transrectal or transperineal? When you put a cohort of multiple patients, they are almost the same and there is no significant difference. Infection-related complications with a transrectal was 2.6%, with the transperineal was 2.7%. the question was only that all the transrectal patients had one dose of antibiotic, probably a ceftriaxone or something of a cephalosporin second generation, and the transperineal where it was totally avoided. So one single dose of antibiotic prior to a transrectal prostate biopsy with no antibiotic on a transperineal ultrasound biopsy had similar infection rates. I think Dr. Subudhi should head this investigation of transperineal versus transrectal in anterior zone tumors. Yeah. So in the perfect and prevent, confirming the pattern. So an MRI targeted significant cancer detection, again if you see, numerically favored the transrectal versus the transperineal. These are two completely different studies. Both of them saying that transrectal detected marginally more than the transperineal route, but not statistically different. Okay, so but this specifically was designed as the transperineal is a non-inferior trial to a transrectal route. It didn't say that transperineal was a better route. Again, if you see the infection rate, 1.4% for the transrectal and 0% for the transperineal. And cancer detection, as I already said, is not significant. So what still differs in practice? Pain and tolerability. Transperineal biopsy is often reported more painful. Procedure time, transperineal biopsy takes more time than the transrectal. Cost. The probe PC's comparison cost effectiveness found the two approaches were comparable when both the complications and the repeat procedures costs were included. That means if you include the cost of the antibiotic, with including the post-procedure, if the patient came back with fever or anything like that, they are comparable. Rare major complications such as severe sepsis requiring hospitalization, still yes, marginally lower with the transperineal biopsy across most data sets. So what are the guidelines say? As I said, because of Trexit 2020, completely abandoned transrectal procedures. European guidelines say transperineal, no transrectal. American Urological Association are more towards us. They say, yes, you can do both. You can use either approach, citing similar cancer detection rates. NICE was historically neutral, but now they are also going towards a transperineal route. Do we have any clarity on this? So basically what I've done is complicate this question even further by these randomized controlled trials, that assuming that the transperineal is superior to transrectal, because for cancer detection and infection rates overall, both the techniques had similar findings. So what is the practical takeaway? Both are reasonable. Cost remains an important decision maker. Local expertise, equipment, and access to a larger tertiary care center will decide whether the patient undergoes a transrectal or a transperineal prostate biopsy. And larger multi-center trials are required, as Dr. Subudhi has said, to be perfectly matched to say that the cancer detection rates were same or different in each of the routes. So I rest my point. Thank you very much. It's been a lively, very encouraging session for all of us. And I thank each one truly for attending this session with full interest. And I think none of us have gone asleep in this session. So that means my job has been well done. Yes, sir, please. There is no question which is funny. Yes, sir. You fail to put a finger in the rectum, you'll have to put your foot in your mouth. That's what it was. Yeah, yeah. Sir, I think I started off before we started this session on MRI prostate. That honestly, the first question I asked was, how many of us put a finger in each and every patient? And obviously the answer is not much, not many. You mean to say? No. When your residency, you do it 100%. He's asking when you become a consultant. Yeah. Thank you for the question, sir. Thank you one and all. Yeah, one more question, please. Yeah. I am biased because I am a urologist. So I would give the lesion contouring and targeting to the radiologist and do the biopsy myself. No, sir. Once the radiologist has read the MRI, and if he does the contouring and he marks the lesion where it is, then it's just fusing our live images with the MR images. That's it. So there's no great skill involved in that.
So we have actually trained our urologists.
Yeah,
well. So
I agree.
He's better than the best probably now. So he does all the contouring well, and therefore his results also are very good.
Thank you, sir. Thank you one and all. So we have a Eurolift session at 4:30. We have a sacral neuromodulation session during the same time. So would request the audience, whichever you are interested, you can attend both. Eurolift also we have simulations where you can do it on the simulator. Sacral neuromodulation, we have the expert Dr. Baswaraj here, who is our expert on sacral neuromodulation. And at 1 o'clock I think we start the robotic workshops. Yeah, thanks a lot. So whoever wants to try on the MR fusion simulation, you're welcome. We have the guys from BK who will be more than happy to assist.
Should we start now? So we are from BK Medical. So in fusion we have three approach. One is transrectal ultrasound MRI guided fusion approach, where we use this triplane transducer. So we call it triplane because there are three areas. So one is transverse, sagittal, and the end fire. So in fusion we basically use a small GPS kind of system. So this is electromagnetic transmitter, and the sensor is placed on the probe. So there is a Trexra box which is a sensor, and the transmitter is connected to the box, and the information is given to the system. So this GPS is like it gives the information of the movement of transducer to the system, and the MRI data which is already there, it is like a map. So as I explained, we have three approach basically. One is transrectal approach. Then we have transperineal freehand. So we will use a transperineal transducer there. In transperineal we have two approach. One is transparent freehand. So transparent freehand is just like a conventional workflow you do just for the biopsy. And the second one is the stabilized version. In stabilized, we use the SURGX stepper, where probe will be placed on the stepper, and it is fixed basically. And your both hands are free to do the biopsy. So we will start with the transrectal now. So probe is connected to the system, and the tracker and the sensor is also connected. Then so in advance we will import the patient data. So it is common in the laptop also, in the system it's same thing. So we import the data, and after importing we click on the sample view, click on start procedure. Then we enter the patient name. So here we are using this phantom. So MRI data is already connected. So we select the patient. So after entering 1 or 2 alphas, it will automatically detect. So you select the patient, and we have 3 approaches: this transparent, transrectal, and transparent free. So first we are showing the transrectal. So we select the transrectal and click on start procedure. So when you click on start procedure, system will give this other progress. Click on start procedure. So system will read the red star from the sensor, and it is showing the value here. So this value should be 0 or 1. So when it is 0 or 1, then it will rightly follow the movement of the user. So then you insert the probe, the phantom, and after inserting, then the probe is inside the patient. Then you will adjust the extra sensor. So this one will be 0. You can place from like 8 centimeter to 66 centimeter. It should be sometimes there can be some interference in some metal parts there. So when it is 0 and 1, then so when fusion is active, it is showing the contour which is done in the right. lower part it shows the MRI data, and the upper one is the real-time data. So you insert it and you see the axial image of the prostate. So there we are using triplane transfer. So the transverse sedator and the head. So we first which right now it is a transverse view. Yes. So first we roughly match it. So there are in the right corner, these are the, this first one is to shift the position. So press the enter button and shift the control. And the second one is the rotation. So if you want to rotate it, select it and you can rotate it accordingly. So it should roughly match. You don't have to rotate the probe. No. So first the matching, the MRI data, the contour and the live image. And after that, we click on the lock fusion. When fusion is low, now this it will follow the contour. So the contour is only with the ultrasound. Okay. So then we it is not matching, so we can shift it. So that it is matching. Okay. So then we check it in the other plane, so in the sedator. So in sedator also match it. So this matching, here you can see it is bigger than the prostate because this MRI is not from this. So after doing this, it is ready for the biopsy. So now click on the next and so here we need to rotate it like slightly. We go to the beside the right one, patient in the left lateral position, lower is the left side. So we rotate it anti-clockwise, it is going to the left side, and so when we rotate clockwise, it is going to the left side, and when you rotate anti-clockwise, it is going to the right side. And because in this is the MRI data, there are two lesions. So one is on the right side, so one is on the left side, one is on the right side. And as you rotate it, so accordingly the image you will see it. Okay. So anything in the suspicious? Yeah, this one is on the right side and other one is on the left side. Okay, so this is the biopsy needle trajectory. So your needle will be like coming like this. So your target should be on the line. Okay.
So basically, he's trying to promote his BK ultrasound fusion. That is what he's doing. Anyway, I agree with that. Only one thing is because they have something called as predictive fusion of the image. Why it is so costly is only because of that. Because MRI is being done in a supine position, whereas we do biopsies either in the lithotomy or in the left lateral decubitus position. Now, if you do an MRI in one position and then do the biopsy in another position, obviously your targeting will not be the same. Previously, the hindrance to targeting biopsies was this: that patient's MRI is being done in one plane and you are doing the biopsy in another plane. The contouring and the targeting itself used to take a lot of time, which many of us urologists never ventured into because it is a headache. Now with this predictive fusion software, the issue is, as I think if you have seen, the virtual probe is shown in the software. So if the patient's victim is this way, turn the virtual probe this way. Victim is this way, virtual probe this way. So after we fix this, confirm this alignment of the grid, any position patient is in, even if he's in head down flexor position, even prone position, the fixity of the target with the lesion with the contour of the prostate will be changed. So that one predictive fusion aspect of BK, nobody else is being able to replicate. And tell what is important. Target lesion won't be missed. Yes, sir. So this matching can be done in between because sometimes patient moves, so you can match it. It will take no less than a second. So your target should be on the line. And these are distance between two dots is 5 mm. So your biopsy gun will travel 2 cm.
So if you fire it from here, so it will go up to here. Okay. So and this shows a virtual core also, the green line. So after taking the biopsy, you can fix it. So it will show on the MRI also, and it is based on here also. So you rotate the probe slightly and you get another biopsy. So like if I take the second one, so in the MRI data also it is also showing that you have taken two sheets. So you can rotate it. You can find out at which location the core is there, or it is outside or so this way. And in high image also, when you come to the same position again, it will show that it is already taken. So this way you can avoid that location and you can take it. So when you take the multiple samples, then it will generate a report also. So you can click on display report.
Completed 90% will be 90% or
Prostate.
prostate resection.
No, it is
This
just
is
a
prostate
biopsy.
biopsy.
It's a biopsy. So it depends on you how many samples you take. So it will create a complete report. So there it will show the number of samples. So it will keep on adding automatically. You need not to select something separately. And it will show the data, control data, and the sample where we have taken. And it will show the 3D data also. And it will take a screenshot as you click on as you fix this core, it will take a screenshot and it is recorded. And then you can send the sample to the pathology. You can enter the pathology report also, location, disease, core length, cancer length, ratio, and perine reason as well. And then you can store it in the PDF also, and the structural report also, you can give it to the patient. For transperineal, we have two approaches. Same one is transperineal one. Workflow is same, which is transperineal and transperineal. And then we place this. Clamps are there because of transporting the miss that, so take it. Otherwise, clamps are there, so it is fixed. And in transperineal, so workflow is same as the case, and the second one is transperineal stabilizer.
Where do you fix the needle here?
The biopsy guide will be fixed on here. It will be fixed here. So there will be two channels. One is for the side file and one is for the end file.
You don't have it. This is the guide.
No, this is not the guide. So it will fix here. Same like this. So but it will be the other channel.
For that you have separate biopsy or the same bar?
Same bar. Same
biopsy
biopsy.
is the same.
And it's stepwise we use the simple stepper. So there are few controls. So it will be fixed on a attachment which is fixed on the rail of the table. And there are few movements like with this you can insert the probe in and out. And the guide will be fixed here. So the tablet will be like this.
It's transparent. So we connect this echo-stepper to the system. Say it is what we connect the biopsy guide, it will get trajectory, it will show the trajectory. This is a transferable code, it has gone through the rectum inside. It is gone through the rectum also. Yes. This is the image that they are going to, this is the grid that we will see. Yeah. Where means, how will you decide?
Actually there is a grid which will be coming here, it's been missed during the transportation, that's why we
So grid is applied on the patient's perineum.
Yes sir, it will
and
be.
Then from which grid needed, according to this number we have to insert the grid.
Exactly.
So now, sorry, just a minute. So here is the target lesion. So we
Yes
have
sir,
to
so we have to put 4.5 and here small b. So corresponding 4.5.
That we have, there we have to insert the lesion.
Yes.
So what is the depth, how will you decide?
So actually it will be in sagittal session. Once we go to the next step, this image will be turned into sagittal session and transfer session will be displayed here. So you can mark it from this transfer session and you will be seeing the depth in the sagittal session. So you will get to know where exactly you are taking
Yes,
forward.
Never seen it.
Scroll through. It's already been done. Yes, yes.
It is parallel to the
This is different, it seems. This interface is different, it seems. Try to and see whether but here it does not have this different version. First we have to like align it, then we can give this. It's already getting it active. I'll mark some of this. Then you just
Take rotation is to awareness. Okay. This is requirement stabilizer.
Yes, there will be a stabilizer, sir. And once the stabilizer will be fixed on the bed rail, and this will be mounted on the stabilizer. So then what happens is both of your hands will be free. So you can just rotate this probe with the knobs available there, and you can match it. Since we haven't received it. Yeah, this one. Okay, so now you can see that the upper one will be sagittal session and lower one will be our transverse session.
So here, sir, we capture all the base to apex, and it will show the contour. So if your target is in the 1 or 3 and C, like this. So you rotate it. So as you rotate it, this line will also rotate. So your needle is in plane with the probe. And that particular
You have any video of them doing that?
I have to check this.
So depends on the product. It's a biopsy technique. So you take the biopsy, you send for the report. So it will not give the report, create it, and then you enter the results from the pathology. That report can be shared. Cost, sir, there are 3 approaches.